Hey there, this is Sarah with Chapter 19, Trauma and Stressor-Related Disorders. Here is the objectives for this chapter. So we're going to look at the history of PTSD because it's only been in the recent history, and by recent history I mean in the last 20 or 30 years, that PTSD has been recognized. However, people have been suffering from PTSD since the beginning of time because people have always been under stress, been stressed out by various wars and traumatic events and personal traumatic events, and so people have really struggled with PTSD for hundreds and hundreds and thousands of years, but it's only within the last 30 or so that it's gotten any recognition and study. So post-traumatic stress historically was known as shell shock, battle fatigue, accident neurosis, or post-traumatic neurosis. And little was written about the disorder prior to 1950 and also between 1950 and 1970. Starting in the 1950s, they started to look at PTSD somewhat more so than the previous, thousands of years, but they didn't actually study about it and write about it. In the 1970s, there was a renewed interest in the disorder, or just the development of a scientific interest in the disorder in response to problems that were being encountered by the Vietnam veterans. And the diagnostic criteria of post-traumatic stress disorder, or PTSD, first appeared in the 1980 in the third edition of the DSM-3, which is the precursor to the DSM-5 that we have today. More than half of the individuals, of all individuals, will experience a traumatic event in their lifetime, but less than 10% will develop PTSD. And a traumatic event is one that is described as outside the range of the usual human experience. The disorder appears to be more common in women than men, but they don't know why. And individuals who have difficulties with stress reaction to more normal events, quote-unquote normal events, may be diagnosed with having an adjustment disorder, and we'll also talk about that later. Adjustment disorders are quite common, and these can occur at any age. So, post-traumatic stress disorder. This is a reaction to an extreme trauma, which is likely to cause pervasive distress to almost anybody who encounters that trauma, such as natural or man-made disasters, Hurricane Katrina, Hurricane Sandy, some of the forest fires that we've had. Combat, of course, would be an extreme trauma or trauma situation. Serious accidents, witnessing the violent death of others, being the victim of torture, terrorism, rape, or other crimes. So what is PTSD? PTSD is an intense reaction to a traumatic event, and the event or events involve actual or threatened death or the actual or threatened serious injury to the individual. It is experienced, it is witnessed, so the traumatic event is either, or the potential traumatic event is either experienced or witnessed. And the response involves intense fear, helplessness, and horror. Now, post-traumatic stress disorder is a normal reaction by normal people to an abnormal situation. And it's the situation that's crazy, not the person. And that's really, really important when you are working with people who have PTSD. And also when you're explaining PTSD to the general public. Because the general public really doesn't understand PTSD very well. Now, there's three classifications of symptoms. There's a persistent re-experience of the event, there's a persistent avoidance of things associated with the event, and then there's persistent problems with increased arousal. Now, just a word about flashbacks. People who are truly having a flashback are not mentally in the present time and place. They dissociate and think they are in a different place and time. For instance, if someone is having a true actual flashback, they will, instead of being in 2014 Lewistown, Montana, in their mind they think that they are actually in 2003 in Baghdad. And that is an actual flashback. Now, the word flashback has become part of slang, but if there's no actual dissociation, then it's probably just an intrusive memory. Okay, so people who have PTSD they can have one or more of the following symptoms of re-experiencing the event. They can have those intrusive memories. Now, just because intrusive memories are not actual dissociative type flashbacks, they can be very, 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 very real and very, very intense and very, very alarming. They can have very, very intense nightmares, the flashbacks that we already talked about. And then intense reactions to cues or symbols of the event can be emotional or physiologic. Other types of behaviors is obvious avoidance of many things. They'll avoid thinking, feeling, or talking about the event. They'll avoid activities, places, or people that remind one of the event. And they may be unable to recall significant parts of the event. Not as obvious avoidance techniques or strategies used by somebody who has PTSD are a marked diminished interest or participation in important activities, this feeling of detachment or estrangement from others, and also they have a restricted range of emotions and a sense of a foreshortened future. With regards to persistent and increased arousal, they may have two or more symptoms that were not present prior to the event, those being hypervigilance, exaggerated startle response, irritability or outbursts of anger, just very sudden and irrational rage, difficulty falling or staying asleep, and difficulty concentrating. Other criteria for PTSD. These symptoms have to have occurred for more than 1 month, and these symptoms need to cause significant distress or impairment in social, occupational, or other important areas of functioning. Now, events associated with developing PTSD. And again, this is experiencing or witnessing emotional, physical, and or sexual abuse, sexual assault or rape, natural disasters, man-made disasters, such as 9/11, witnessing violent or gruesome deaths, and then being victims of violent crime or being a victim of a war atrocity. PTSD statistics, 60% of men experience a major trauma. 5% of those go on to develop PTSD. And 50% of women experience a major trauma, and 10% of those go on to develop PTSD. 30%, it is estimated that 30% of Vietnam veterans developed PTSD, 10% of Gulf War veterans, 11 to 20% of the OEF and OIF veterans, and 7 to 8% of Americans at some time in their lives will develop PTSD in response to a traumatic event that they experience. So who's at risk? What are some of the predisposing factors that put someone at risk for developing PTSD? And this is kind of the magic question, because you can have, let's use veterans, for example. You can have two veterans go to the same place, experience the same types of trauma, and one will develop PTSD and the other will not. You can also have two veterans who go to the theater of war, and they may not actually experience a traumatic event, but they're always at risk for experiencing a traumatic event. They're always at risk for roadside bombs or what have you, but they may not actually experience a roadside bomb. Now, you can have one of those soldiers who is, okay, well, we went over, we didn't meet a roadside bomb, and they're fine. And then the other one, the stress, that anticipatory stress of, yes, but we could have, can actually make them develop PTSD. And we don't know why one person develops PTSD and the other doesn't. But they think that some of the predisposing factors are that the person has had an earlier traumatic or life-threatening event, childhood history of emotional, physical, or sexual abuse. They have another psychiatric problem, either diagnosed or undiagnosed. They have a family history of psychiatric problems. Let me double check we're recording here. Okay, good. A personal history of abuse of alcohol or drugs, recent loss of a loved one, recent stressful life changes, being female, being poorly educated, and being very young. Those are the predisposing factors. Now, those that are more likely to develop PTSD are those that are directly exposed to the trauma, either as a victim or a witness, those that are seriously hurt during the event or permanently disabled from the event, the trauma is long-lasting or severe, or that you believe you or a loved one or family member was in extreme danger during the event. And then the last thing is that they felt helpless during the event or helpless to assist others during the event. Now, PTSD in women. 1 in 3 women will experience a sexual assault at some point in their lives. They're more likely to experience domestic violence because although there are women who abuse men in the domestic violence situation, it is statistically more likely that men will abuse women in domestic violence. Women are more likely to blame themselves for the trauma. It may take longer for women to recover. They may have a higher startle reflex, avoidance levels, or levels of avoiding the situation and reminders, and also a higher level of numbing. And they're more likely to experience depression and anxiety with their PTSD. Now, with PTSD in men, men are more likely to be exposed to violence other than sexual assault. So gun violence, other types of violence, as so forth. They're more likely to show anger and have problems controlling their anger when we're talking about the PTSD symptom of just sudden and irrational anger and rage. Men are more likely to show the anger and rage. They're more likely to abuse alcohol or drugs, and they're less likely to seek treatment. Now, with regards to PTSD in children, you have to look at how severe was the trauma, how did the adults in the child's life react to the trauma, how far away is the child from the trauma, how far away in the past is the trauma. Events that involve violence are more likely to cause PTSD than natural disasters. And you always have to keep in mind what's the developmental age of the person. A 5-year-old is going to react very, very differently from a 14-year-old. And that's because they're at different developmental ages. So, a word about PTSD symptoms and alcohol abuse. Lots of people use alcohol just generally to self-medicate. And if somebody doesn't recognize the PTSD symptoms in themselves, which occurs a lot, people can be suffering from PTSD and they just they don't realize it. They don't recognize it. They just think, well, I have an anger management problem, or I'm just a loner. I don't want to interact with anybody. That's just how I roll. And it, and a little bit more investigation turns out that they actually have PTSD. But they may self-medicate with alcohol and drug abuse. Now, alcohol increases that emotional numbing and social isolation. The anger, the irritability, the depression, and the hypervigilance. Nightmares and intrusive memories may be decreased while under the influence. However, when the person withdraws or goes through periods of abstinence, the nightmares and intrusive memories may increase during this period of withdrawal. Flashbacks may increase while under the influence of alcohol, and person who is under the influence of alcohol having a flashback may be very, very resistant to reorientation to reality. So if you're trying to reorient them to, you are here, this chair is real, the floor is real, the bed is real, they might not be able to reorient. Alcohol abuse, somebody who has an alcohol abuse problem, this is going to interfere with the PTSD treatment. Co-occurring PTSD and alcohol abuse disorders are more likely to also have a third comorbid medical and psychiatric disorder of mood disorder, panic disorder, chronic physical illness secondary to that alcohol abuse, autoimmune disease secondary to that alcohol abuse, and then chronic physical pain due to permanent injury. So, is it PTSD? It depends. Gender, age, and past history are going to influence how a person reacts. Now, a response that is out of proportion to the situation may be due to underlying PTSD. The flight or fight reactions are those extreme reactions that produce extreme amounts of adrenaline to make it so that a person can fight or flight. And somebody who is suffering from PTSD, they will have those extreme adrenaline rushes when they're when their SNS system is determining, do I fight or do I flight, the PTSD or the memory of what they've gone through. A word about children. The flight or fight in children, oftentimes instead of fleeing, they will just freeze. They will completely freeze in their situation. Women with PTSD may react negatively to male police officers. Children who have only known aggressive and abusive men may also react negatively to male police officers. And always remember, intoxicated people, whatever their drug of choice is, are going to be unpredictable. War veterans experiencing flashbacks may confuse persons in a police uniform as an enemy combatant. Minority children may have been told that the police are the enemy, and that would be part of their childhood socialization. If there have been previous negative experiences with uniformed police, the anticipation of another negative experience can also trigger extreme reactions. And the other thing to remember is that lights, sirens, and harsh tones can also trigger PTSD. So you have to, when you're going into a situation, you have to look at all of these and incorporate, what you're dealing with. Some veteran-specific considerations is how warriors view things and how veterans view things is different from how a doctor and nurse is going to view something. And you really have to know this, because especially when you're working with veterans, their worldview is oftentimes completely different from the Western nurse and doctor worldview. Now, and this is going to influence the expectations of returning veterans. Now, just some perspectives on stress. The warrior view is that stress is a weapon of war. Stress is essential for training. It's an unavoidable friction in war. It's a test of manhood, and exhibiting stress symptoms are shameful. So that's the warrior view. The doctor-nurse view is that stress is a toxin to be avoided. It's the cause of illness. It's suffering to be relieved. Stress can be seen as cruel, and stress symptoms are only human, and we need to identify them and deal with them and move on. So you can see how that is a completely different worldview on both sides. Both of them are fine. It's just a different worldview. Now, the expectation of returning veterans, the expectation of the veteran, the family, the loved ones of the vet, is that the veteran is going to return to be exactly the person that they used to be. Now, the reality is that transitioning from military to veteran status is an ongoing process. And part of this process is accepting that you can never be a civilian again. And veterans and their families need to adjust to the vet being changed forever. The person coming back is going to be a different person. One, they're going to be older, and two, they've gone through this very intense experience that is going to change them. And so they can't be the person that they used to be. And sometimes we need to just explain that and educate that to loved ones, family members, and also medical staff. Now, PTSD treatment for vets. All VAs or VA hospitals, they're all different. When you've seen one VA hospital, you've seen one VA hospital. And the treatments at the different VA hospitals, while they try to be aligned, they are very, very different. One treatment that seems to be having some success with veterans who are experiencing PTSD is called prolonged exposure therapy. And this is a type of therapy that has a couple of different stages. And in the first stage, they educate the veteran about PTSD. Believe it or not, some people have no idea that PTSD is the reason that they're having these problems that they're having. And we educate that it's a normal reaction to an abnormal situation. We educate about the physiological responses and changes. For instance, when you have that adrenaline rush with that fight or flight, which is in response to that intrusive memory, you're going to have all of those flight or fight responses. Increased heart rate, increased hyper awareness, increased irritability, increased, everything is increased. And this is just a response to that PTSD process. And we also educate that PTSD is a reaction to living in fear of what's going to happen. And it's an anticipatory anxiety for those flashbacks and those intrusive memories. So first stage is a lot of education. The second stage is breathing retraining techniques, and they're taught how to breathe and how to calm themselves down when they're having panic attacks, while they're having their flashbacks and intrusive memories. The third stage is imaginal exposure, and this is where it's all hard, but it gets really hard in this third stage, this imaginal exposure stage. And this is where they tell the traumatic event or story, and they tape record their traumatic event or story. And they talk about the most traumatic events, and not just a traumatic event or the sort of traumatic event. They have to talk about the traumatic event that is really giving them all these problems with PTSD. And that can be kind of hard because people understandably don't want to talk about their traumatic event. It's painful. It's incredibly painful. And with this type of therapy, they have to talk about it and examine it and tear it apart. And it's very, very painful. And they have a lot of homework to go home and do this. And what they'll do is they'll tape their traumatic events, and they'll write, and then they'll listen to that taping, and they write down whatever emotions come up. And the reason for this is two main things. Now, in the time of the event, especially with someone who's a soldier, there's no time for emotion during that situation. All they can do is react and get the heck out of that situation. And so there's literally no time for reaction and emotion during the event. And so the grief and the loss and all of the emotion is put in a box and put away. And so now is the time when they can deal with all of the emotion, all of the grief, all of the loss that they need to deal with in order to process the event. And so basically they do this and they repeat many, many times over the course of 4 to 9 months. And over this course of 4 to 9 months, other memories are also going to come up and have to be dealt with. Now, one thing I want you to keep in mind, a lot of times what people will do to veterans and also other people who have gone through traumatic events is you say, just buck up and forget about it. You just need to forget thinking about it. Don't think about it. Asking a vet to just forget about their dreams and memories is like asking a mother to forget about her child. You can't do it. And but what's going to happen is that person is going to put it in a box and they're going to put it away, and they're not going to deal with what they need to deal with. And then you're going to have those behaviors and anger and all the symptoms that we discussed earlier are going to show themselves. All that emotion has to come out one way or the other. So what can you do as a nurse? During the acute PTSD episode, so somebody is either having a flashback or having a very, very intrusive memory, the most important single thing you can do is stay calm and in control. You need to use an easy tone of voice, speak softly, calmly, very slowly, use non-threatening hand gestures, acknowledge the emotion of the situation. I can tell you're really scared. I can tell you're really angry. Work to keep things in the here and now. And sometimes you have to say, John, you are here. You are here with me in this room. You are on that chair. That chair is real. Keep things very, very concrete, very, very real, very here and now. You may have to use those physical surroundings to orient the person if they're very, very panicked or disoriented. And then you also need to stress non-harm to self and safety of the person. Some other things you can do, be conscious of height differences. If you're standing over the person who is having an episode, you're in a threatening position. And so be aware of that. Ask questions one at a time, and you're going to have to wait for the answer. You might have to wait 1 or 2 minutes for the answer. Assist them with slowing any rapid breathing, doing those deep breathing exercises. If the victim is a frightened woman or child, consider waiting for female personnel. Sometimes this will really, really help, because part of that PTSD experience that they're having, if they are afraid of men, they're going to be afraid of men. And so So you may want to wait for female personnel. Don't make any promises you can't keep. Don't offer false assurances, but you can offer optimism and hope. So if they say, I'll tell you this, but you can't tell another soul, don't say, oh yeah, no problem. Don't make that promise, because you can't keep that promise. You're going to tell everybody. That's part of the reason that they're there and you're a nurse and you're helping them with this. What you can say is, I can tell that you are suffering and I can tell that you are in pain, but it doesn't always have to be this way. We can help you through these programs. There are things we can do, there are medications we can give to make this suffering stop. It's going to take time, it's going to take a lot of work, but there is hope to make this stop, so you won't always feel this way. And then try to establish something the person feels they can control, no matter how small. And honestly, it might be, do you want water or milk? Do you want chicken or beef for dinner? You know, all those things that give them something they can control. Some special considerations. Be very cautious about touch. Some people are very, very touchy-feely and they'll hug everybody. Somebody who has PTSD may not want to be touched. They'll have that hyperactive startle reflex and hypervigilance reflex anyway, and be very cautious about going in for a hug or something like that. Sometimes it's appropriate and sometimes it's best not to. For veterans, consider acknowledging their sacrifice. You know, thank you for your service. If dealing with small children, think about a favorite blanket or toy that they may have as a levy or a security item. If you're dealing with the elderly, be aware of possible hearing loss, vision loss, confusion, lack of mobility. If you're dealing with someone who is visibly psychotic, don't block the exit. Okay, stand to the side of the exit, stand away from the exit, whatever it takes, but do not block that exit. That will just probably end up in agitating them even more. Another thing is, you need to know yourself. Know what your strengths and weaknesses are. What types of interactions are going to annoy you or anger you the most? Now, none of us are angels. None of us are perfect, and all of us have our own triggers. And we need to know what those are, so that if those get triggered, we can deal with that annoyance or anger and just know that it's our problem. You really need to know who or what pushes your buttons. And then also pay attention to your own stressors. And you can use the HALT mnemonic. Are you hungry, angry, lonely, or tired? If you have any of these going on in your life, your buttons are probably going to be pushed more often and more easily. So another population I want to talk to you about is nurses and PTSD. Nurses are at higher risk for PTSD, 14% risk, which is 4 times the rate of the general population. ICU nurses are at 25%, a risk of 25%. ER nurses, 33%. Other nurses, like mental health nurses, military first responders, and L&D nurses, or labor and delivery, are also at higher risk. And the reasons for this being at higher risk is that they have a repeated exposure to people who are hurt and dying. They're on the front lines, and they have a risk of being threatened with violence, especially if you work in a social system that is very, very violent. If you work in an inner city ER, you're going to be exposed to people who are very, very violent and coming in with very violent situations. Feelings of helplessness if the nurse perceives patients can't be helped, which we help as many as we can, but some patients we can't help. For whatever reason, we're unable to help them. They may have the nurse herself or himself may have a history of violence or abuse as a predisposition factor. They may numb. Which may, in nurses, this presents as minimizing a layperson's loss. So a person comes in, they're very, very old, they come in, they're coded, they're a full code, their family's there, a beloved elder in the family, and the person dies, and the nurse says, well, you know what, they died, but too bad, so sad, they were old, it was just their time to go. That's very callous. That's very, very callous. And saying that, in front of the loved one, it just presents as numbing. They may be irritable, and this may present as passive-aggressive behavior rather than than traditional irritability. The traditional male presentation of irritability is like anger or rage, and in nurses this may present as like passive-aggressive behavior. So somebody comes in with needing a shot, and by gum, you're going to use the biggest needle there is because you can. You know, that's what it'll present. That's what irritability presents as in nurses. Avoidance. This in nurses may present as a lack of self-care or a lack of care for their immediate family. And then re-experiencing. The nurse may be unable to leave work. They'll have high levels of anxiety regarding any care that they've missed. And they don't trust their co-workers to pick up the shift where they left off. So mental health care for nurses. This is something nurses have to do for themselves if they're going to take care of themselves and have a long career in nursing. You have to get appropriate sleep, exercise, and diet. You just have to. You have to make it a priority. And this is really, really hard when you're working shift work, especially if you're working evenings or nights. It's really hard to get definitely appropriate amounts of sleep. And then fitting in exercise and diet is very difficult also. Maintain and develop hobbies and outside interests outside of medicine. Create a private time to unwind, but avoid isolation. Make yourself do social activities. You just make yourself do them. Even if it's the dumbest thing ever, make yourself be social. Make sure you have spiritual fulfillment, whatever that means to you. For some people, it's going to church. For other people, it's communing with nature. Watch your alcohol limit, watch your alcohol intake. When you drink, limit yourself to 1 to 2 drinks, and don't start drinking daily. You really have to watch that because nurses and medical people are really at high risk for self-medicating with alcohol, basically is what it comes down to. Assess any perfectionism and obsessive habits of thinking. Being a perfectionist, we almost have to in a lot of ways because there's very little room for error. But you need to assess that. Is the perfectionism helping your job or is it hurting your job? Is it helping the amount of care you can give to your patients or is it hurting it? Address any personal history of abuse or violence, past or present. Be kind to your colleagues. Try not to eat your young. And then nurses who are moms. You know how when you're on the airplane and they always tell you put your oxygen mask on before you place it on your child? You have to do that. You have to take care of yourself. Otherwise, you're going to burn out and you won't be good to yourself, you won't be good to your family, and you certainly won't be any good to your patients. Here are some articles of interest that are just really good articles with regards to PTSD in nurses. And then here are some other references that are just references for PTSD. Some of them are PTSD specific, and some of them are mental health general. Okay, so now we're going to talk about acute stress disorder. Now, acute stress disorder is similar to PTSD in terms of precipitating traumatic events and symptomatology. Symptoms are limited up to 1 month following. However, in this case, the symptoms people experience, they occur up to 1 month following the trauma. If the symptoms last longer than 1 month, the diagnosis is going to be a PTSD. Now, why do people develop trauma-related disorders? Your book has a couple of theories. There's psychosocial theory, learning theory, cognitive theory, and biological aspects. The one that makes the most sense, I think, is psychosocial theory. So I'm really going to go into that, but know that you have to know the other ones also. Now with psychosocial theory, this has become a widely accepted theory, and it seeks to explain why some individuals exposed to massive trauma develop PTSD and others do not. And the variables that include characteristics that relate to the traumatic experience, the individual, and the recovery environment. Now with regards to the traumatic experience, the specific characteristics of the trauma have been identified as crucial in determining the individual's long-term response. So they look at the severity and duration of the stressor, the event of anticipatory preparation for the event. So this is somebody who is under a lot of stress anticipating what can happen. whether or not it happens or not. Exposure to death, numbers of people affected by the threat to life, amount of control over the reoccurrence, and then the location where the trauma experience. Was it in familiar surroundings, like in the home, or was it in a foreign country? So with regards to the individual, individual characteristics depend on the degree of ego strength, effectiveness of their coping resources, presence of pre-existing psychopathology, either diagnosed or undiagnosed. What are the outcomes of previous experiences with stress and trauma? What's the general temperament of the individual? Are they a high-strung individual, or are they pretty relaxed and mellow? What's the current psychosocial and developmental age? What are the demographic factors, age, socioeconomic status, and education? And then with regards to the recovery environment, this is the environment that the person recovers from their PTSD in. Now, the quality of the recovery environment in which the individual attempts to work through that traumatic experience is correlated to the outcome. And the environment variables include the availability for social support, the quality of that social support. They may be in a family, but that family dynamic might be very, very toxic. Other environmental variables, the cohesiveness and protectiveness of that family and friends, the attitude of the society they live in regarding the experience. I'll tell you, the attitude of our society today with our returning Iraq and Afghanistan veterans is very, very different from the society that the Vietnam vets returned from. It's completely night and day. And that has a huge effect on how our vets are going to be able to deal with their PTSD. And then the cultural and subcultural experiences. Now, in research with Vietnam vets, the best predictors of PTSD were the severity of the stressor and the degree of social isolation in the recovery environment. Now, the other theories, learning theories, cognitive theory, and biological aspects, read over those and be familiar with those, but I'm not going to go over them right now. So nursing diagnosis. The nursing diagnoses are going to be formulated from the data collected during that assessment phase. They're probably going to have either post-traumatic syndrome or complicated grieving. Outcome criteria. Basically, we use these outcome criteria as measurement guidelines to evaluate the effectiveness of nursing care. So we look at, can the patient acknowledge the trauma and the impact on his or her life? Some people, they'll say, yeah, I went through that. Yeah, it was rough after, but I'm fine right now. Meanwhile, they're not sleeping, they're not eating, they're hypervigilant. They get up several times during the night to check the locks on their house. They're not okay. This is having a huge impact on their life, and so they're not at that outcome yet. Can they demonstrate adaptive coping strategies? Do they have realistic goals for the future? Have they worked through their survivor's guilt? Oftentimes a lot of a huge factor is survivor's guilt. Why am I here and my buddy's not? Why am I back here with my family and he or she is not? Are they able to attend support groups of individuals recovering from similar traumatic experiences? And then are they able to verbalize a desire to put that trauma in the past and progress with their life? And that is a lot easier said than done. Nursing care, basically we reassure their safety. We want to also help them decrease their maladaptive symptoms. We want to help them learn and demonstrate, make it so that they are able to demonstrate more adaptive coping strategies, and then make it so that they're able to demonstrate the adaptive progression through that grieving process. Evaluation. Can the client discuss the traumatic event without experiencing panic levels of anxiety? Has the client learned new adaptive coping strategies for assistance with recovery? Okay, so now we're going to talk about stressor-related disorders. And these are adjustment disorders and some predisposing factors to that. Adjustment disorders are characterized by maladaptive reactions to identifiable stressors or stresses that result in the development of clinically significant emotional or behavioral symptoms. Symptoms occur within 3 months of the stressor and last no longer than 6 months. And there's a couple of different types of adjustment disorders. There's adjustment disorder with depressed mood, and this is the most commonly diagnosed one. And this is when somebody has a depressed mood disturbance, but less depression than one who has an actual major depressive disorder. The symptoms are the same: depressed mood, tearfulness, feelings of hopelessness, and they exceed what would be expected with a normal response to a stressor. There's adjustment disorder with anxiety, and in here the primary response is anxiety. Adjustment disorder with mixed anxiety and depressed mood, and so here they have the symptoms of depression and anxiety. That is more than would be expected in a normal response, but less than what you need for a diagnosis of depression or anxiety. With the adjustment disorder with disturbance of conduct, this is when the person exhibits conduct in which there's a violation of the rights of others, or it's a violation of major age-appropriate social norms and rules. For instance, truancy, vandalism, reckless driving. They might have some fighting, default on the legal responsibilities, and this needs to be differentiated from a diagnosis of conduct disorder or antisocial personality disorder. And if you have somebody who has a conduct disorder and they also have an adjustment disorder or PTSD, it can get really difficult to tease out what is what. So some of the predisposing factors, there are biological theories, genetic theories. They think there might be some vulnerability related to neurocognitive or intellectual developmental disorders. Let's see, there's psychosocial theories, where their childhood traumas, arrested development, what's their constitution, are they mellow, are they high-strung? All of these predisposing factors seem to play a role, but you can have two people who have the same exact predisposing factors, and one gets an adjustment disorder and the other doesn't. So it helps, but it doesn't totally explain it. So nursing diagnosis for adjustment disorder: complicated grieving, risk-prone health behavior, and anxiety. The outcome criteria for adjustment disorders: is the client able to verbalize acceptable grieving behaviors? Are they able to demonstrate a reinvestment in the environment, accomplish their ADLs independently? Are they able to function adequately in their personal life, in their work life, their social life? Are they able to accept the change in their health status, set realistic goals, and are they able to demonstrate that they're able to cope effectively with the change in their lifestyle? Nursing interventions and planning are aimed at helping them progress through the grief process. And so we do a lot of explaining on what the grief process is. And, when we're talking about the 5 stages of grief, remember that people don't go from A to B to C to D. They jump around, and as they go through life and have different life milestones, they can go right back to the beginning and have to go through the grief process again. It should get better. It should not easier. It should the response should be less and less as they go through the grief process, but it's not a linear thing. They'll jump all around in the grief process, and we have to explain that is normal and to be expected, and they're not going crazy. We want to help the client achieve acceptance of a change in their health status, and then assist them to maintain their anxiety at a manageable level. Evaluation is based on the accomplishment of the following criteria. Does the client demonstrate progression through the grief process? Does the client discuss the change in health status and whatever modifications to their lifestyle that it's going to have? And then is the client able to set realistic goals for the future? Okay, so treatment modalities. I talked about a couple in detail previously, but there's a lot of them. And these are discussed in detail in your book, and I want you to read through them and have a working knowledge of them for the test. The thing you need to realize is that one size doesn't fit all, and sometimes the individual needs to try a couple of different methods and a couple of different providers until they find one that works for them, and it can be really difficult. And sometimes if they're at a point in their PTSD process, they may not be able to help themselves, and so then their caregiver or support person needs to be educated on, you know, these are the different treatment modalities. Have you tried this? Have you contacted this person? And let them know that they may have to try a couple of different things before they find the thing that works for them, and to not give up and not stop seeking treatment until they find one that works for them. And here are just some other types of therapies.